Hello, everyone. My name is Wasim Hanif. I'm a professor of diabetes endocrinology in Birmingham. Today, we will be talking about advances in the management of type 2 diabetes, focusing on the latest guidelines. In my talk today, I'll probably try and take you through some of the recent evidence that has come into light in the last 3 years. And this evidence is going to have a huge impact on the way we practice or treat our patients with type 2 diabetes. The latest guidelines that have come around actually reflect this. So the focus now, as you would see in my talk, is shifting from just glycemic control to the whole cardiovascular renal management, or what we call the cardiovascular renal metabolic management of diabetes. Let me just start in my first slide that diabetes actually confers the highest lifetime risk of coronary artery disease of any single factor. So, if you have somebody with diabetes compared to those without diabetes, your risk of having coronary artery disease increases by nearly 57% in women and nearly 67% in men. So, by just having diabetes, you substantially increase your risk of coronary artery disease. Not only you increase the risk of coronary artery disease, people with diabetes tend to develop coronary artery disease about 15 years earlier than those without diabetes. And this again, especially true for women in whom the protection that is afforded when they are in the childbearing age is lost the moment they develop diabetes. Now let us try and understand what is happening in the last 2 decades for diabetes management. And here we'll be focusing only on three things. One is all-cause mortality, death from cardiovascular disease, and death from CHD. And this is the data from the Swedish National Diabetes Register. And what it shows is that we have done extremely well, both in people with diabetes and without diabetes, especially in those without diabetes. So you can see the all-cause mortality has been coming down in the last 2 decades. Similarly, the death from CHD, as well as death from coronary heart disease. But what is a bit of a paradox is that even though people with diabetes, the all-cause mortality is coming down, it is still higher, and so high that it's nearly lagging 20 years behind than those without diabetes. Now, diabetes is not only a story of coronary artery disease, but it's also a story of heart failure. Now, conventionally in diabetes, there are two types of heart failures that have been described. One is what we call the HFrEF, or heart failure with reduced ejection fraction. This is the heart failure you develop that you have diabetes, then you develop coronary artery disease or atherosclerosis. You have a myocardial infarction, the heart muscle gets damaged, and it is not able to pump properly. So when you do an echocardiogram in these patients, the ejection fraction is less than 50%. But there is another type of heart failure that is described in diabetes, and this is seen in patients who don't have coronary artery disease but occurs quite early on in diabetes. Various terms have been used to describe this, things like diabetic cardiomyopathy, diastolic dysfunction, or what we call the HFpEF. In these patients, when an echo is done, the ejection fraction is usually more than 50%, and these patients are difficult to treat. The reason about heart failure is important in diabetes is it increases your risk of dying if you have got diabetes and heart failure. And secondly, one of the biggest costs in America and in the UK is when the patients with heart failure are admitted to the hospital. Not only is heart failure an important factor in diabetes, the kidney disease is also important. So how long you live with type 2 diabetes is actually decided by the state of your kidneys. So if you have got proteinuria or a falling eGFR, your risk of your risk of dying with diabetes increases. And this data actually shows that diabetes kidney diseases shortens your lifespan by nearly 16 years, and that's a huge amount. So, what do we have when it comes to management of cardiovascular risk factors, and how do they affect? So, if we just focus on macrovascular disease and not microvascular disease, we know that controlling blood pressure or using antihypertensive therapy, especially with ACE inhibitors or angiotensin receptor blockers, improves improves mortality, decreases cardiovascular risk. Similarly, control of LDL cholesterol by the statins has a positive effect on cardiovascular risk. Similarly, antiplatelet therapy, especially post MI and secondary prevention work. But what about glycemic control or controlling diabetes? The current evidence is not very strong, and we'll look into it. Secondly, what about weight loss and other lifestyle interventions? And again, the jury's out because the evidence for supporting this is not very is not very strong. So if we look at intensive versus standard glucose lowering and look at all-cause mortality and see how it is affected, what we find in this forest plot is you've got all these major clinical trials which basically look at intensive versus standard monitoring, huge number of patients. And what all these trials show is the line is close to the unity, slightly favoring glycemic control. Glycemic control was strongly favored for reducing mortality in UK PDS, while in a study like ACCORD, it actually showed your increased risk of dying. So when it comes to just glucose lowering to lower the mortality, the evidence is not very strong. One of the factors of this could be the type of therapies that we use in these clinical trials, which were mainly sulfonylureas or insulins or glitazones, and did not have the new therapies. Now, the year 2007 is perhaps very important in improving our understanding of managing type 2 diabetes, especially when it comes to cardiovascular risk factors. In this year, in New England Journal of Medicine, Steve Neeson, a cardiologist from the United States, published a meta-analysis. And this meta-analysis was actually looking at rosiglitazone to see what rosiglitazone did. And what he found in this analysis was there was a significant increased risk of MI and an increased risk of cardiovascular death. Although this paper could be debated whether this meta-analysis was proper or not, it really changed the way diabetes was looked after. The reason for this was that the FDA, the Food and Drug Administration in the United States, mandated from then that any new drug that was to be launched for diabetes needed to have what is they call a cardiovascular outcome trial. And what they wanted in this cardiovascular outcome trial was to show that the new drug was safer or it was non-inferior in terms of causing cardiovascular death when compared to the old therapies. If it showed superiority, it was well and good, but it had to show non-inferiority. Following this mandate by the FDA, there were a huge number of clinical trials that were done. And if you just go through this, you will just see the number of clinical trials were done. And these included all class of agents. So they included the DPP-4, the SGLT2, and the GLP-1. These three class of agents that were launched. And this really had a huge impact in improving our understanding of diabetes. So what did this clinical trial show? So the first set of clinical trials were done with the DPP-4 inhibitors. And what was also mandated was that each of these clinical trials would have what they called a 3-point MACE that included non-fatal MI, non-fatal stroke, cardiovascular death, and they could have an additional uh, um, 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 primary endpoint that could be decided by the investigators. So if you look at the 3-point MACE, you had trials like Savior-TIMI with saxagliptin, Examine with alogliptin, Ticos with sitagliptin and Carmelina with linagliptin, and all of them had their points at the bar of unity in the forest plot, showing that all these drugs were safe and they did not increase your risk of dying, but did not offer any superiority. When it came to the hospitalization for the heart failure, there was a slight increase in the saxagliptin and the alogliptin clinical trials, while this was not seen in the sitagliptin or the linagliptin or the linagliptin clinical trials. After this, there were a number of clinical trials that also reported with GLP-1 receptor agonist. The first of these was the Alexa study with lexasenatide, which again showed no superiority, but showing that it was pretty much close to the line of unity. Then you had trials like LEADER with liraglutide, which clearly showed clinical superiority or cardiovascular outcome superiority in terms of 3-point MACE, and similar thing was seen in the SUSTAIN 6 study with semaglutide. With Excel, numerically with Biduron, there was a positive signal, but this was not statistically significant. So overall, the GLP-1 receptor agonist did show a positive cardiovascular outcome clinical trial. There was another clinical trial that with a GLP-1 agonist. This was the Rewind study. Again, this showed a positive result in terms of the 3-point MACE with 12% relative risk reduction. But Rewind with dulaglutide was slightly different from the other GLP-1 receptor agonist trial because predominantly the patients in the Rewind study did not have a cardiovascular event, so they were in what we would call in the primary prevention arm. Secondly, the median follow-up with dulaglutide was much longer. It was nearly 5 years, while in other clinical trials it was between 2 to 3 years. So it was a longer trial in primary prevention. Again, it showed cardiovascular protection. Then we had a number of trials with the SGLT2 inhibitors, the EMPA-REG, the CANVAS, and DECLARE-TIMI. The EMPA-REG and CANVAS showed reduction in the cardiovascular outcomes for the primary for the primary endpoint, while in the DECLARE-TIMI there was numerical reduction but not statistical reduction, but there was a statistical reduction in the other core primary endpoint in this trial, which was cardiovascular death and hospitalization for heart failure. So if we look at the meta-analysis of the SGLT2 inhibitors trial in terms of MACE, which was published by Zenka et al. In Lancet 2018, what we find is that there were two groups of patients. So in the first group of patients were the ones who had ASCVD or established cardiovascular disease, and the second were who did not have cardiovascular disease but just had the risk factors. In those with the ASCVD, there was a positive trend seen in the reductions of cardiovascular event or 3-point MACE. But those with the risk factors, this was not seen. Similarly, if you look at the hospitalization for heart failure, again in these trials, the benefit was seen in both groups of patients, those with ASCVD as well as with the multiple risk factors. Now, in the last early this year, there was another clinical trial that was published, and this clinical trial is slightly different from the cardiovascular outcome trials. This was the DAPA-HF study. It had nearly 5,000 patients, but interestingly, it has patients with diabetes and those without diabetes. Only about 45% of the patients had diabetes. The rest did not have diabetes at the time of joining the trial. The primary endpoint in the trial was the time to first occurrence of any of the components of the composite CV death or hospitalization for heart failure or an urgent heart failure. And what this trial showed was when it came to its primary endpoint, there was a 26% relative risk reduction, and the numbers needed to treat was just about 21, with an absolute risk reduction of 4%, which are quite big. And as I mentioned earlier, this included patients without without diabetes as well. We also had the Credence trial with canagliflozin, and this was in patients with kidney disease with an eGFR of as low as 30. And what we were trying to achieve in this clinical trial was more towards the protection of the kidney. So if you look at the primary composite endpoint, there was a 30% reduction, which was highly significant, and similar results were seen in doubling serum creatinine, ESKD, renal death, and CV death. And if you just look at the numbers needed to treat, for primary composite outcome, it was just 22, which is much lower than most of the statin trials. And for end-stage kidney disease, doubling of serum creatinine, or renal death, it was 28 patients. So in this trial, canagliflozin was not acting by lowering the glucose, but more acting by a different set of mechanism to protect the kidneys. And I think this is very important, and this has had an impact on the way we look at the guidelines. So in the first part of my talk, I just gave you an idea about diabetes is not only about glycemia, it is about cardiovascular risk, it is about cardiovascular events, it is about the renal events. And I've also took you through the current evidence, which has actually focused not only on glycemia, but on reduction of other risk factors by some of the new therapies as evidenced in the new clinical trials. Now let us try and look at the guidelines and see how this has impacted or will impact the current guidelines. So the purpose of any guidelines is to guide clinical decision making, to grade the strength of recommendations, to guide the regulators and payers in making interventions available, and to highlight the areas where the evidence is lacking. So if you actually look at the evolution of type 2 glucose lowering guidelines over the last 20 years or so, what we find is initially before 96, it was more about control of symptoms. Then we had the UK PDS, where we started controlling the sugars more tightly in order to reduce microvascular complications and in a way have an impact on the macrovascular complications. Then we had the accord and the advance and the mandating of the FDA CVO2 trials. Again, till 2014, the focus was on glycemic control with individualized management. And from 2018, with the new clinical trials coming in, the focus is shifting more on cardiovascular risk. So if you go back in time and remember in 2006, this is how the ADAST consensus document for managing diabetes looked like. A lot of emphasis on glycemic control. This is how it looked in 2012. Again, this was about individualization of treatment. This is how it looked in 2015. It was pretty much metformin, and then any of the therapies for diabetes could be used, and the use of this therapy was dependent on individualization, dependent on the patient and the choice that the physician and the patient made together. But after these trials were published, in 2018, the ADASD consensus statement came. It was published at the EASD in Lisbon, and this is how it looked like. So what the ADASD consensus statement now said was the first line therapy was metformin, but after that you had to ascertain that the patient had established the ASCVD, or what they call atherosclerotic cardiovascular disease, which meant that the patient had a previous MI, previous stroke, or peripheral vascular disease, or had chronic kidney disease. And if ASCVD predominates, then you should have used GLP-1 or SGLT2, or if the patient had heart failure or CKD, which predominated, then one could use SGLT2 or GLP-1. If the patient did not have established ASCVD or CKD, then the choice was pretty much to decide what was the most important thing for the patient. If it was hypoglycemia, then DPP-4, GLP-1, SGLT2, or TZDs could be used. If it was weight, then GLP-1 or SGLT2s could be used. And if it was cost, then one could use either sulfonylurea or a TZ or a TZD. But if you go by these classifications, only about 25% of the patients would qualify for GLP-1 or SGLT2 therapy on this side of the chart, while 75% of the patient would come on this side of the chart. So the key points of the ADSD document was shared decision making, classifying the patient depending upon the comorbidities or the weight and hypoglycemia, and choosing GLP-1 as GLP-2 therapies accordingly. In 2019, the ACA and AHA guidelines on the primary prevention of cardiovascular disease and treatment of type 2 diabetes were published. The ACC and AHA guidelines had a slightly different take on things. And what they said was that if the HbA1c was less than 7 and after the patient was on metformin, it had to be ascertained whether the patient had cardiovascular risk factors, not established disease, but cardiovascular risk factors. And if the patient had cardiovascular risk factor, then the consideration should be given to start the patient on SGLT2 therapy or GLP-1. So the summary of the ACC and AHA guidelines was metformin first line. If the patient had ACVD or the risk factors, then SGLT2 or GLP-1s should be used to improve the glycemia. But in 2019, the European Society of Cardiologists came up with their own guidelines for managing diabetes, prediabetes, and cardiovascular disease. And in this guideline, they focused on three cardiovascular risk categories. One was what they called the very high risk, the second was high risk, and the third was moderate risk. So very high risk patients were those who already had target organ damage, either established ACVD, heart failure, or kidney disease. The high risk patients were those who had a high risk of developing any of these events, and moderate risk were young patients with type 1 diabetes aged less than 40 years. And what they said was in these group of patients, SGLT2 inhibitors or GLP receptor agonists with proven cardiovascular disease benefits are recommended in the patients even ahead of metformin. So which group are they talking about? So recommendation for glucose lowering patients for patients with diabetes. Recommendation was empagliflozin, cana, or DAPA are recommended in patients with type 2 diabetes and cardiovascular disease or at a very high or high cardiovascular risk to reduce cardiovascular event. Similarly, GLP-1 analogs, liraglutide, semaglutide, or dulaglutide are recommended. Similarly, in patients who've got heart failure or high risk of developing heart failure, then either EMPA, cana, or dapagliflozin could be recommended. And finally, in the patients who have got lowish EGFRs, then either cana, EMPA, or DAPA could be recommended up to an EGFR of less than 30 to less than 90. So how are things? So this is the way I look at the current diabetes management. A lot of it is based on primary prevention. We try to prevent diabetes, try to prevent our patients from developing complications. Once they develop atherosclerotic disease, it is all about hypertension, dyslipidemia, lifestyle management to prevent the patients from developing end organ damage. Once they develop end organ damage, it is about protecting the kidneys. And finally, it is about protecting the heart failure. So this is what I call a diabetes, cardiorenal, and heart failure continuum. So the summary of the ESC guidelines on diabetes, prediabetes is the first guidelines to recommend SGLT2 or GLP-1 receptor agonist prior to metformin in patients with established ACVD or very high severe risk patients with type 2 diabetes. The guidelines move beyond treatment of patients with type 2 diabetes based on primary and secondary prevention classification. And in my last slide, I will leave it with this, and this says it all. Thank you very much.